Hello everyone, my name is BAKSHI PUNEET. Today we will discuss about the examination of musculoskeletal system.
Hello, how are you?
I'm fine, doctor.
What's your name?
Sanjay Bakshi.
Do you have pain on your any body part?
No.
Okay, so today we will examine your musculoskeletal system.
Okay.
First inspection. Inspect the shoulder and shoulder girdle anteriorly, then the scapulae and related muscles posteriorly. Note any swelling, deformity, muscle atrophy or fasciculation. Look for swelling of the joint capsule anteriorly or a bulge in the subacromial bursa under the deltoid muscle. Survey the entire upper extremity for color changes, skin alteration or unusual bony contours. Now palpation. Begin by palpating the bony contours and structures of the shoulder, then palpate any area of pain. Begin medially at the sternoclavicular joint, then from behind palpate the acromion, then coracoid process, greater tubercle, bicipital groove and tendon, and at last subacromial and subdeltoid bursae. Now we will examine the range of motion. First, flexion. Patient instruction should be like raise your arm in front of you and over the head. For extension, the patient instruction should be like raise your arms behind you. For abduction, patient instructions should be raise your arms out to the side and over the head. For adduction, patient's instruction should be cross your arm in front of your body. For internal rotation, the patient instruction should be place one hand behind your back and touch your shoulder blade. For external rotation, the patient instructions should be raise your arm to the shoulder level, bend your elbow and rotate your forearm toward the ceiling. Adduct the patient's arm across the chest. Ask the patient to touch the opposite scapula. If the patient touches the scapula from upward side, it tests the abduction and external rotation. If the patient touches the scapula from the lower side, it tests the adduction and internal rotation. Press on the scapula to prevent scapular motion with one hand and raise the patient's arm with the other. This compresses the greater tuberosity of the humerus against the acromion. Flex the patient's shoulder and elbow to 90 degrees with the palm facing down. Then with one hand on the forearm and one on the arm, rotate the arm internally. This compresses the greater tuberosity against the supraspinatus tendon and coracoacromial ligament. Ask the patient to fully abduct the arm to shoulder level up to 90 degrees and lower it slowly. Note that abduction above the shoulder level from 90 to 120 degrees reflects the action of deltoid muscle. Elevate the arm to 90 degrees and internally rotate the arms with the thumbs pointing down as if emptying a can. Ask the patient to resist as you place downward pressure on the arms. First inspection. Inspect the position of the hand in motion for smooth natural movement. When the fingers are relaxed, they should be slightly flexed. The fingernail edges should be in parallel. Inspect the palmar and dorsal surfaces of the wrist and hand carefully for swelling over the joint or signs of trauma. Note any deformity of the wrist, hand or finger bones as well as any angulation. Observe the contours of the palm, namely the thenar and hypothenar eminences. Note any thickening of the flexor tendon or flexion contractures in the fingers. Now palpation. In palpation, first palpate the wrist joint, then palpate the anatomic snuff box, palpate the metacarpophalangeal joints, then distal interphalangeal joint where you may find Haberden nodes, and proximal interphalangeal joint where you may find Bouchard knots, which are common findings in osteoarthritis. Now we will examine the wrist range of motion. First, for flexion, patient instruction should be: with palms down, point your fingers toward the floor. For extension, the patient instructions should be: with palms down, point your finger toward the ceiling. For adduction, which is also called radial deviation, the patient instruction should be: with palms down, bring your fingers toward the midline. For abduction or ulnar deviation, the patient instruction should be: with palms down, bring your fingers away from the midline. Test hand grip strength by asking the patient to grasp our finger, which is second and third fingers. This test function of wrist joint, the finger flexors and intrinsic muscles and joints of the hand. To test thumb function, ask the patient to grasp the thumb against the palm and then move the wrist toward the midline in ulnar deviation. Ask the patient to place the fingers and thumb in the neutral position with the palm up. Then have the patient move the thumb anteriorly away from the palm to assess the abduction. Test TINEL sign by tapping lightly over the course of the median nerve in the carpal tunnel. To test PHALEN sign, ask the patient to press the back of both hands together to form right angle. This maneuver compresses the median nerve. First inspection. Inspect the gait for a smooth rhythmic flow as the patient enters the room. The knee should be extended at the heel strike and flexed at all other phases of swing and stance. Check the alignment and contours of the knee. Observe any atrophy of the quadriceps muscles. Inspect for any loss of normal hollows around the patella, a sign of swelling in the knee joint and suprapatellar notch. Note any other swelling in or around the knee. Next, palpation. Ask the patient to sit on the edge of the examining table with the knees in flexion. In this position, bony landmarks are more visible and the muscle, tendons and ligaments are more relaxed, making them easier to palpate. For palpating the tibiofemoral joint, face the knee of the patient. Place your thumb in the soft tissue depression on either side of the patellar tendon. Identify the groove of the tibiofemoral joint. Note that the inferior pole of the patella lies at the tibiofemoral joint line. To palpate the medial and lateral menisci, press on the medial soft tissue depression along the upper edge of the tibial plateau with the tibia slightly internally rotated. Place the knee in slight flexion and palpate the lateral meniscus along the lateral joint line. For palpating the patellofemoral compartment, locate the patella and trace the patellar tendon distally until we palpate the tibial tuberosity. Ask the patient to extend the knee to make sure the patellar tendon is intact. Now for palpating the suprapatellar pouch, start 10 cm above the superior border of the patella, well above the pouch, and feel the soft tissues between the finger and thumb. Move your hand distally in a progressive steps, trying to identify the pouch. Continue your palpation along the sides of the patella. Note any tenderness or increased warmth. Check 3 other bursae for bogginess or swelling. Palpate the prepatellar bursa. Palpate over the anserine bursa on the posterior-medial side of the knees between the MCL and the tendons inserting on the medial tibial and plateau. On the posterior surface with the knees extended, check the medial aspect of the popliteal fossa. To examine the knee range of motion, first flexion. The patient instruction should be bend or flex your knee or squat down to the floor. For extension, the patient instructions should be straighten your leg or after squat down to the floor, stand up. For internal rotation, the patient instruction should be while sitting, swing your lower leg toward the midline. For external rotation, the patient instruction should be while sitting, swing your leg away from the midline. With the knee extended, place the left hand above the knee and apply pressure on the suprapatellar pouch, displacing or milking the fluid downward. Stroke downward on the medial aspect of the knee and apply pressure to force fluid into the lateral area. Tap the knee just behind the lateral margin of the patella with the right hand. Place the thumb and index finger of your right hand on each side of the patella. With the left hand, compress the suprapatellar pouch against the femur. Palpate for fluid ejected or ballooning into the spaces next to the patella under your right thumb and index finger. To assess large effusion, you can also compress the suprapatellar pouch and ballot or push the patella sharply against the femur. Watch for the fluid returning to the suprapatellar pouch. With the patient supine, grasp the heel and flex the knee. Cup your other hand over the knee joint with fingers and thumb along the medial joint line. From the heel, externally rotate the lower leg, then push on the lateral side to apply a valgus stress on the medial side of the joint. At the same time, slowly extend the lower leg in an external rotation. The same maneuver with internal rotation of the foot stresses the lateral meniscus. With the patient supine and the knee slightly flexed, move the thigh about 30 degrees laterally to the side of the table. Place one hand against the lateral knee to stabilize the femur and the other hand around the medial ankle. Push medially against the knee and pull laterally at the ankle to open the knee joint on the medial side. With the thigh and knee in the same position, change your position so that you can place one hand against the medial surface of the knee and the other around the lateral ankle. Push laterally against the knee and pull medially at the ankle to open the knee joint on the lateral side. With the patient supine, hips flexed and the knees flexed to 90 degree and feet flexed on the table, cup your hand around the knee with the thumb on the medial and lateral joint line and the fingers on the medial and lateral insertions of the hamstring. Draw the tibia forward and observe if it slides forward like a drawer from under the femur. Compare the degree of forward movement with that of the opposite knee. Place the knee in 15 degree of flexion and external rotation. Grasp the distal femur on the lateral side with one hand and the proximal tibia on the medial side with the other. With the thumb of the tibial hand on the joint line, simultaneously pull the tibia forward and the femur back. Estimate the degree of forward excursion. Position the patient and place your hand in the positions described for the anterior drawer test. Push the tibia posteriorly and observe the degree of backward movement in the femur.